I welcome all the respected seniors and colleagues for this first academic activity of West Zone of AMASI along with the Vidarbha Surgeon Association. Today we have a very interesting lecture by Dr. Prashant Rahate sir on a very interesting topic, that is application of indigocyanin green dye in general surgery. How, where, and where we can use and how can we use it. So various uses and applications in different kind of clinical scenarios and surgical situations. Dr. Prashant Rahate sir is going to tell us. So Rahate sir, kindly start the lecture.
I think Gode sir and Samir should.
Okay. Samir?
Yes, sir. I welcome you all to the first ever activity of the new Executive Council under the presidency of Dr. Varghese. A new structure has been formed by AMASI. So we are going to have different zones, of which I have been selected as president of the West Zone. Dr. Rahate is our own faculty, eminent laparoscopic surgeon from Nagpur. He's been given the responsibility of joint secretary. We have our past president, Dr. Gode sir, to guide us every time from the West Zone. And we are delighted to have him in each and every meeting and guide us at every junction wherever we want. First innovative activity I think Dr. Rahate and Gode sir have planned is to educate us about this new technique, what we have to embrace to have maximum safety in all possible surgeries. And that is what I think Dr. Rahate is going to emphasize. If we can improvise safety features in each and every part of surgical activity with intermixed with the technology, I think he would be a better person because he's been using this product for a long time. I welcome you all and hope we have multiple meetings on different topics of minimal access surgeries so that we propagate knowledge and safety skills to each and every person in surgical community. Thank you.
Thank you, sir. Gode sir, a few words from you as well.
Thank you, Dirbal. Respected President of the Zone, the respected President of the VSN, Dr. Girish Jatkar, the faculty Prashant Rahate, and all other delegates. In fact, this zonal activity has been started now, which was to be started almost 10 years before, but nobody really paid any attention. And we thought that zones would not only consolidate the strength of AMASI, but this would give chance to the juniors to participate.
वो लेकर मैं बताता वहां चले जाओ अपना क्या बोलते हैं जो अपन इधर अभ्यास एग्जैक्टली दुर्गा देवी इंस्टॉल होती उसके पहले लेफ्ट साइड में एक चाबी वाला है दुकान है प्रॉपर वो बहुत होशियार आदमी है 200-250 रुपए में वो चाबी रिपेयर कर नई चाबी बना के देता पुरानी चाबी पर रिपेयर कर देता
आतिश
No, mute. Let admin mute all, please.
अरे म्यूट करना भाई तो अपने आप.
So who could? Am I audible?
Yes, sir. Yes, sir. Kindly.
So I was just telling that this is one step, a step forward to strengthen the AMASI and involvement of juniors, especially who could. I mean, this is making the platform available to everyone. I congratulate the president of this zone that and also the Dr. Nirmal and the faculty, Dr. Prashant, that this is the first ever activity of the zone in all over the country. So I'm very proud that the thing has started from Nagpur. I wish all the best, and this step, especially today's lecture, is a part of inculcating the culture of safety amongst the laparoscopic surgeon. So I congratulate both of you, Prashant and Nirmal, for selecting this topic. And we would, as AMASI body itself and AMASI West Zone itself, we would always take these safety precautions and let this culture of safety be developed amongst the juniors of the members of AMASI, so that our patient is given or extended a safe treatment. Once again, I wish all the best to this zone. Special best wishes to Samir, and I hope from next time even the people from Gujarat and Goa should be actively involved into our activity. So thank you very much, and my best wishes to all of you. Thank you.
Thank you, sir.
Thank
Thank
you,
you
sir.
so much.
Thank you,
Thank
sir.
you so much, sir. So can we now start with the lecture, sir, Prashant, sir?
Yeah, I am sharing. I think
Yes,
you will have to mute all. Yeah. So thank you very much, Samir and Gode sir and Jatkar sir, for allowing this activity to be there. Yeah. So uses of ICG in general surgery, that is the near infrared fluorescence angiography. This is to see better, treat better, operate better, and the results are better. So my disclosures, though the topic is related to the use of commercial equipment, I have no disclosures. And welcome all to AMASI, West Zone, and VSA. Uses of near infrared imaging in general surgery are many. If we see, we can classify these uses into detection of vital structures, that is hepatocyte, and ureters. The tissue perfusion we can see in various scenario, the resection anastomosis, colorectal, esophagus, then flap surgeries, the arterial anatomy of different this thing, even in diabetic foot, liver perfusion, splenic perfusion, in bariatric surgery, and recently this particular modality has been added to see the embryonal plane detections in surgery, particularly the abdominoperineal dissection, the right hemicolectomy or left hemicolectomy. Then lymphatic mapping. Lymph nodes are very important in particularly in malignancy surgery. So sentinel lymph node biopsies, various lymphatic detections, particularly gastric cancer, colorectal cancer, even the thoracic duct can be detected, localized during surgery with the help of ICG. And detection of various tumors can be done. Nirmal, can you mute? I think I will have to do that. Mute all.
sir, you are.
Yeah, I have muted. So, detection of the tumor. Am I audible? Yes. Okay. Then in various tumors such as in liver as well, pancreatic tumors, the adrenal gland, breast, lung, brain, parenchyma saving tumor surgeries. This is again a newer modality of treating tumors. And then parathyroid detection, which is an enigma in itself. So there are miscellaneous uses also. We will see videos of everything. Lap sleeve, Heller's myotomy, undescended testes, varicocele surgery, fistula, pilonidal sinus, and hemorrhoids. So we will see this one by one. So when MBBS student or undergraduate student learns about the biliary duct anatomy or biliary anatomy, he sees the picture like this. But when he first enters into the abdomen, the picture is like this. So that is what the student has learned in his undergraduate days. That type of anatomy we can see by this ICG. So ICG is GPS of the surgery. There are various types of infrared imaging. For open surgery different, and for laparoscopic surgery different. In open surgery, we have handheld camera, and for laparoscopy, obviously the telescope can be used there. And there are various modes of this ICG. or the infrared imaging, that is pi fluorescence overlay fluorescence, we will see what exactly is this and what is the utility, clinical utility of this, the color segmented fluorescence and the color maps. So the spy contrast or the black and white image, which you are seeing on your the first image, that is the black and white fluorescence image, that gives you idea about the volume of perfusion. What is the percentage of blood which is flowing through the arteries? You can see the arteries, there is a lot of fluorescence there, and tissue there is less fluorescence, because in arteries the concentration of the dye is more, so they are more illuminated. In the middle picture, that is spy overlay, there is green overlay of the white image, and that can give you the transition point where exactly the perfusion has stopped, and or where exactly the perfusion is reaching. And in the third image, that is the blue image, which you can see the depth of perfusion. The second image, that is the green image, will not tell you whether the mucosa is also perfused or not. Here only we can see the serosa that is perfused. But in this particular image, we can comment that whether the mucosa is also perfused or not. So depth of perfusion can be seen. So there are various types of staining. One is the positive staining and one is the negative staining. Positive staining means the disease. Here, the upper image, the tumor is illuminated, and that indicates that the pathology is illuminated. That means the positive staining. And here the rest of the normal tissue is illuminated, but the pathology is not stained, so that is negative staining. This is because this particular patient had a hemangioma in the liver. So hemangioma has rapid blood flow, which will take away the ICG, and therefore there will be negative staining. But on the contrary, the liver tissue, the liver cells will retain the ICG dye, and therefore it will be stained. And in the upper image, the tumor has more affinity for ICG dye, and therefore it will retain the dye for more than 6 days, 7 days. But that time, the liver cells will completely push the dye into the biliary tree, and that dye will disappear from the circulation. But in the malignant cells, it will be retained, and therefore there will be positive staining. So these are the types of staining. There are various timing and doses in depending how exactly that dye is to be given, and how it is to be given. What is the dose and what is the modality of giving? So that depends on the system which you are using and the indication. What is the indication of the or the pathology? In cholecystectomy, it is to be given 90 to 30 minutes before. If you want to see the vascular anatomy during cholecystectomy, you have to give in bolus dose immediately. But the dose will be higher, that is 3 ml. But if you want to give it to see the biliary anatomy, you will have to give it 60 to 90 minutes before, but that the dose will be only 1 ml. So similarly for lymphatics, it will be for 30 to 60 minutes before. And if the organ preserving, such as for parathyroid adrenals, we have to give infusion in very weak dose, that is 0.25 ml per minute dose. In malignancies such as for liver, pancreas, lung, it is to be given more than 3 to 5 days before you are planning the surgery. In organ vascularity, we have to give it again in bolus dose. When we want to see the embryonal planes, we have to give the dye intra-arterially. In rest of all the indications, we are giving it either locally infiltration or intravenous. But when we want to see the embryonal planes, we will see the video of that. Then we have to give it intra-arterially. Then there are certain local installation of dye, such as inhalers, then sleeve. If we want to see the ureters, local installation of the dye. So what is this ICG? Why it is fluorescent in infrared imaging? This type of material or this type of chemicals, they are called as fluorophores. So ICG is not the only chemical which is illuminant in the infrared imaging, but depending on the indication, such as 5-ALA can be used in neurosurgery instead of ICG. And there are many other fluorophores, they are coming up. Methylene blue is one. Then Zitronics, they are used for the kidney. Then there are certain chemicals which are not yet named, such as IR dye 800 CW. They are used for the oncological surgeries. There are various dyes which are specific for a particular malignancy, such as pancreatic malignancy, there is a different dye. Then colorectal malignancy, there is a different dye, and renal cancer, there is a different dye. They are yet to be marketed. But what exactly the NIR, that is near infrared imaging wavelength, that is range from the 650 to 950 nanometer. And the penetration of the depth of the vision is around 3 to 4 millimeter. But in certain handheld cameras, handheld system, the depth we can penetrate, we can see the dye around 1 centimeter below the skin margin. So that is important. And therefore, in many surgeries, we have to skeletonize to see the particular anatomy, because a lot of fat, if it is there above the pathology, then we have to skeletonize it to see the ICG dye. So depth can, for seeing the depth, we have to skeletonize it. Now, this is a very important slide. This slide indicates that how is the affinity of the ICG dye to various pathology or various structures of the body. In fat, it is very low. In muscles, it is extremely low. In blood vessel, it will remain for at least 4 to 6 minutes, not more than that. Then in tumor, in malignancy, it will remain for more days because it has great affinity, as I have already told you. And depending on that, we can plan what time we are going to give the dye. There are certain contraindications. Drug allergies to the iodine dye is one of the contraindication for this particular dye because it is a weak iodine dye. Then there are certain drug interactions with the heparin, so we have to be very careful. Then any studies, radioactive iodine studies can't be performed 1 week after the ICG injection, and in obviously high-risk pregnancy, it is contraindicated at present. So why we are using this particular infrared imaging by ICG technique? It will reduce the leak rate, it will change the resection margin, it can also reduce the diversion rate in colonic malignancies. Then it can reduce the length of stay, obviously, if the leak rate is decreasing. Then it will not cost much of the cost to the patient. Only the hardware, one time it is costly, otherwise the test or the dye is very cheap, and it is also time saving in the surgery. So operative time is also less with ICG, and there are multiple yes to the questions which are there. So we will start with the colorectal surgery and ICG image guidance. We will see this ileostomy vascularity. You can see the end of the loop or the ileostomy which we are planning. We have given the ICG dye, and you can see a scale, red to black scale there on the right corner of your screen. And this dye is appearing now. Red is very good blood supply, black is zero blood supply, and in between is the blue and green. So blue will tell you about around 40% of the blood supply, and green will tell you around 60 to 70% of the blood supply. So here, if I would have done ileostomy, definitely that would have become gangrenous. So we have to resect it, refashion it, and therefore definitely the further complication was avoided. There are multimodality imaging also. In different color, we can see the images. That is because we know that 8% of the population is colorblind to blue and red, and therefore these type of images, they can also be we can get with ICG, the red, yellow, red, then violet. So this particular, even the surgeons also come from the general population. So surgeons are also 8% colorblind, particularly to red and green, and therefore this type of modality can be useful to this thing. So this particular John Anthony Spalding, he has done a beautiful study and has indicated that, had proved that 8% of the male doctors and 0.4% female doctors, they are colorblind. So we will see how the evaluation of this stump vascularity. We know that at present the blood supply is judged by and the anastomotic leak is there because of the compromised blood supply, tension on the anastomosis. There are certain technical factors, skill of the surgeon, marginal artery handling, then stapler problems, and the patient's morbidity such as obesity, diabetes, atherosclerosis, and smoking. There are definitely newer risk factors being added, the intestinal microbiome or the new adjuvant therapies. But this significant inadequate perfusion clearly plays a significant role. And what we are now doing at present, everybody knows that we see the bleeding edges of the during anastomosis. If the bleeding is good, then we are very happy. Then temperature of the tissue, if it is very cold, then we are worried. Then appearance of the tissue, whether it is dusky, blue, then we will resect more. And we can even do palpable, we can even see the pulses, palpable pulses. But these are all notoriously poor predictive value. Even after all these four parameters, there is a leak in the anastomosis. So these are notoriously poor predictive values. So all these things are not acceptable in 2022. So what is acceptable? Acceptable is this: if after doing the anastomosis, visualize the anastomosis from inside as well as from the serosal side. So there is a beautiful grading given by Alessio Piazzo. He has classified the anastomosis by grading it into grade 1 to 3. Grade 1 is pink on either side from the mucosal side. Grade 2 is less than 30% perfusion on either side. And grade 3 is more than 30% less perfusion or compromised perfusion on either side of the anastomosis. So if it is like that, then on serosal side we are seeing, from mucosal side we are seeing and we can refashion if there is a compromised mucosal vascularity. So this is acceptable in 2022. So how this is to be done? Evaluation of the bowel stump perfusion. ICG dilution is done 2.5 milligram per ml and 0.1 milligram per kg is injected intravenously before the bowel resection. And before anastomosis, just after resection, first bolus is given. Second bolus is given after doing the anastomosis, because the half-life of ICG is only 4 minutes in the blood. So we have to see the integrity twice before doing the anastomosis and after doing anastomosis. This is a video giving you the idea. So this was a left hemicolectomy. Now we want to see where exactly we want to do resection of the bowel. So we have given ICG dye and we will see where exactly the ICG dye is disappearing and which area is perfused. So this is the contrast mode. We can see definitely which area is perfused and which area is not perfused. We can mark it and do the resection there. And after that, we can do observation of the mucosa by going through the telescope, inserting into the anus and seeing the vascularity green on either side of the anastomosis from mucosal side. So that is how the vascularity of the mucosa is seen. So this is one case where that will prove my point. We are doing one low anterior resection, and stapling has been done. Then the anvil is inserted, and now we can see very good vascularity. We are firing the stapler. We are bringing the above, so there is no tension at all. Good vascularity is visible, and then we will be giving the dye. So after the dye is given, we will see the vascularity on either side. So dye is appearing beautifully on both the sides of the anastomosis. But what about the mucosal side? We will see it from the mucosal side. Now we are seeing it from the mucosal side, and you can see that the proximal part is not at all well vascularized. So we will have to resect it again, the proximal part. So that is how it is useful. So same thing, the black is least vascular, red is very good vascularity. So we will have to resect in the red margin. So now going ahead with the location of primary. Many times what happens, we are unable to locate the primary when doing laparoscopy because we don't have the haptic sensation. And therefore we can do it, we can instill the ICG dye 24 hours before endoscopically peritumoral infiltration in 4 quadrants around the tumor. Around 3 ml is to be given. So that is how that can be detected very well. So here, many times it is not seen from the serosal side. And we can see localize the tumor very well. And even the lymph nodes can be visualized in similar way. So we will see how the lymph nodes they are seen. This lymph nodes visualization is very important because after doing your TME resection, if there are still green shadows are there, then that means there are still lymph nodes there, so we can resect it completely. R0 resection can be done. So peritumoral infiltration 24 hours before surgery and lymph node visualization can be done. This is a very important slide when we are doing particularly left-sided hemicolectomy or low anterior resection. The lateral pelvic lymph nodes we don't address much because we are more concentrating on the TME dissection. But what happens to this lateral pelvic lymph nodes? Almost 9 to 20% of the patient, they are having lateral pelvic lymph node positivity in left-sided or rectal malignancies. And in clinical application, LPND is limited by various complications because of the ureter and the hypogastric nerves might be damaged without efficient guidance. And for this, using ICG improves the dissection. We will see in video how that improves beautifully. So venous anatomy is also important in colorectal surgery. How that is important, we will see. Visualization of the venous anatomy, because the lymph nodes, they are situated over the venous system. So this is more important, particularly on the right side hemicolectomy, because trunk of Henle, everybody knows how important it is, because this is how the trunk of Henle is there. And we want to dissect only the superior right colic vein. We are not supposed to dissect the right gastroepiploic vein or superior pancreaticoduodenal vein. All the 3 veins, they combine to form a trunk of Henle. But the story is not so simple because there are n number of variations of this trunk of Henle, like this, more than this. And therefore, as we want to do only superior rectal superior right colic vein dissection and the lymph node associated with it. And as the anatomy differs, there are multiple anomalies. So the situation of that lymph node will also differ. So this is the trunk of Henle dissection in right hemicolectomy. You can see beautifully the trunk of Henle, and we can localize the lymph node associated with it, and we can pick that lymph node properly and avoid recurrence at that level. So depending on the variation, lymph node status changes, and therefore the venous anatomy is also important in the colorectal surgeries. So we will see the complete TME anatomical plane or embryonical plane as I was talking about. So how that is to be done exactly, you can see here in this particular picture, a beautiful picture where you can see only ICG dye in the rectum and the sigmoid, but the rest of the tissues, they are completely normal. How that is to be done, we will see. So we will dissect the inferior mesenteric artery, and we will insert, after completely dissecting the inferior mesenteric artery, we will canalize it with the Schledlinger technique. You can see the complete left this inferior mesenteric artery. Yes, yeah, complete left inferior mesenteric artery is clamped, and then we will see how that is cannulated by this Schledlinger's technique. So after applying a bulldog, we give a arteriotomy, and then we'll cannulate it and push the dye. And before pushing the dye, we will release the bulldog clamp. So that has been cannulated. We have ligated over the catheter, and so that there will be no backflow and leakage of the blood. So we are removing the bulldog clamp, and then we are instilling the dye. So only the area which is supplied by the inferior mesenteric artery and which we want to remove, which we want to do left hemicolectomy or anterior dissection or very low anterior dissection, that can be done. Similarly, on the right hemicolectomy, that can be done. So this is video how the embryological planes, they can be separated and cut. So here we are not worried about the ureter, we are not worried about the hypogastric nerves, because they are not at all illuminated. They are not at all green in color. So we are removing only the green tissues. So we are perfectly in a plane. So even the surgeon who is doing it for the first time will go into only that plane. So he will be having a great learning. The learning curve will be reduced, and he will be very safe. So that is how the embryological planes, they can be tackled with the help of ICG dye, and in a better way without any complications. So that is how the lateral lymph nodes also can be tackled with the help of this thing. So embryological plane identification is possible with the help of ICG. So how that is done, the 0.5 milligram per ml of the dye is taken, and it is perfused at the rate of 2 ml per minute. First, we are giving a bolus of 10 ml, and then we are giving a continuous perfusion at the rate of 2 ml per minute. So that is how the dye will concentrate only in the embryological area which we are concerned about, where the artery which we are cannulated, only that particular part will be illuminated. So a better TME dissection sparing all vital structures can be done more rapidly and precisely. So embryonal planes, they are, this is a newer concept where we can go ahead with the ICG technique. And this is very important slide, that intra-arterial, because we have already cannulated the artery. So intra-arterial, intraoperative chemotherapy simultaneously can be given. And this is a beautiful paper, more than 500 patients, a long study, where he has demonstrated proven that almost the local spread and the local recurrence, as well as the distal recurrence or the distal metastasis, the hepatic metastasis is less in colorectal malignancy if intra-arterial intraoperative chemotherapy is given. So this new approach will improve the circumferential resection, locoregional recurrence-free survival, urogenital dysfunction will be saved, learning curve will come down, duration of the surgery decreases due to visual help to find planes, and additional chemo drugs to prevent hepatic metastasis. So if we don't use ICG, the world literature says that there is a 12% anastomotic leak. But after using the ICG dye or this technique, the anastomotic leak comes down to 1.4%. So that is a significant change it has come. There are multiple studies available. Pillar 2 study is very famous, where it has proven that ICG dye use is to be done regularly. There is pillar 3 perfusion that is not very helpful because the study was concluded early and no significant difference was seen, because this particular pillar 3 study was carried out only in very low, ultra low resection, and there not much difference was seen with ICG or non-ICG group. There is a quadruple assessment by Stephen Wexner that ICG decide the proximal colon cut, then air test, or popularly we call that test as the puncture test, to confirm whether there is any leak in the anastomosis. And then we see the donuts, whether they are complete or incomplete, and then intraoperative colonoscopy, white light, and again with the green light, perfusion of the mucosa. He has proved that Stephen Wexner is a famous name, everybody knows him. The fourth group, that the anastomotic leakage was very low. Then there is the iceberg trial, which has again proven that. So there are n number of studies which are available, but the fluorescence imaging is to be done at multiple times, 2 to 3 times during operative procedure. That is very important. Only one time ICG imaging is not complete. So there are questions really to be answered along even after ICG dye studies. The detection rate of true positive. There are certain false positive also, and the detection rate of false positive. What is false positive means? That it is a fluorescent tissue, but it is a non-malignant lesion. Then there is a false negative, that is non-fluorescent malignant lesions are there. We will see the reason. If the blood supply to that malignant lesion is very less, then dye will not reach that particular lesion, and then it will become a non-fluorescent. Then any morbidity or complication related to fluorescence guided additional resection, that is yet to be studied. Change in the duration of this surgery because of these additional resections, additional procedures, and change in postoperative clinical management because of this additional procedure. These are yet to be studied. How to identify the ureter? We do ureteroscopy, put a ureteric catheter and 7 ml of ICG dye into the ureter on either side, and that will remain there for 6 hours. So intraoperatively, you can very well identify the ureters during colorectal surgeries or pelvic surgeries. So that is how a simple test to identify this. This was a patient where the gynecologist inadvertently had gone through the mesenteric border of the intestine while putting his port in a previously operated case. There were adhesions, and he did suturing, beautiful suturing, but there was like this. So we did ICG study there, and it detected that that particular mesenteric border was definitely no vascularity was there. So we proved that because it is non-vascularized, then we will have to do the resection anastomosis, not just suturing. So that is how it will prevent a catastrophe. The fecal fistula and fecal peritonitis will be prevented. So even in we can do the tissue quantification, how much percentage of blood is there, oxygen is there in the tissue. You can see the figure there, 48, 38% here. Then here it is more 40%. Then this particular part more than 60%. So quantification of the oxygen can also be done with this camera system. That is very important, and but that is for the open surgery. So this particular patient had a lung abscess, and we drained that. And the question was whether to do lobectomy or not. We wanted to see the vascularity. So that particular lobe was completely avascular, and therefore we went ahead with straight away with the lobectomy. This is a beautiful picture where diabetic foot, and we can see that the third toe is avascular with little bit bluish toe, fourth toe also. But we will see in ICG that all the four toes, they are avascular. So you can tell the patient very well that chances of forefoot amputation are very high in this particular patient. You can see it. In doing hernia surgeries, lap hernia surgery, we frequently go into the space of radius and put the mesh there and fix the mesh there. But if we think that there is a corona mortis, a very important vessel connection between the external iliac system and internal iliac system, so we give dye and we see whether where is the corona mortis and the connections. There are n number of permutation combination of these arteries and veins permutation combination, and you can see there is this is the corona mortis going toward the obturator artery. So we have to be very careful while doing trackering the mesh there, or if anybody is fixing the mesh during hernia surgery, laparoscopically. So we have to be very careful about these particular vessels. This is, we know from our undergraduate knowledge that there is around the umbilicus, there is caput medusae. So where to put the port exactly in a patient with cirrhosis, that we can know beforehand. These beautiful caput medusae are seen here. So we also know that the splenic artery divides into multiple 2 or 3 branches before going into the splenic hilum. When we apply a clip to a particular artery, we are not sure whether we have given the main splenic artery or branch of the splenic artery. So after applying a clip to the artery, we can push the ICG dye immediately and see whether the complete spleen is becoming green or it is remaining as such, and we can compare it with the color of the liver. So this particular patient, the spleen is remaining normal, not becoming green, liver is green. So we have given a clip at the main artery. So that is how it is very helpful. So inadvertent bleeding around while doing laparoscopic splenectomy can be avoided by this. Even in in rhomboid flap for the pilonidal sinus surgery, we can do. This is very common complication while doing any flap surgeries. The edges, whether they are having good vascularity or not, we can see that. Even in hemorrhoid also, for minimal MIPH and the other procedure, whether the distal part or toward the anal part, whether complete devascularization is there or not, we can see it beautifully by ICG technique. In vascular surgery, while we handle the vessels here in median arcuate ligament, we are handling the tissue, handling the arteries. That handling itself can cause intimal trauma, the trauma to the intima or the endothelium, and it can give rise to the intimal flaps, and it will cause obstruction to the flow of the artery. So that we can detect it during intraoperative ICG technique, whether there is any intimal obstruction or not. So this is possible even during the cardiac surgery, whether the freshly put graft is working or not on table. So lymphatic system can also be very well seen. This is a patient of breast cancer, and we have to put, with the help of the insulin syringe, 0.25 ml of the dye is instilled at 2 level. You can see a scar down here. And you will be surprised to see how much that small scar will make a change in the lymphatic flow. They see the dye is going toward the scar first. That means the malignant tissue here has already gone toward the scar there, which was the surgery was done about 10 years back for some benign condition. So how the lymphatics, they can change their path, and then the lymph nodes are very well visualized. This is the malignancy, how this is seen on ICG mode, that is to be seen, and then the flow of the lymphatics is going toward the axilla, towards the axillary lymph nodes. So we can see the sentinel lymph node and take the biopsy, and depending on that, we will see do whether the modified radical mastectomy or lymph node sparing surgery is to be done. Then identification of thoracic duct during esophageal surgery. Many times that becomes a problem, particularly in irradiated patients. Nowadays, without irradiation, carcinoma esophagus is not operated usually. So you can see the azygous vein there, and by the side, this is the green thoracic duct seen. So how that thoracic duct is to be visualized? We instill the dye intraperitoneally while doing this thoracic part of the surgery. So put 1 ml of dye intraperitoneally around 30 minutes before, and then that dye will be taken up by the lymphatic system, and the thoracic duct can be visualized very well. Lympholymphatic anastomosis, we have seen this. This is courtesy Dr. Somashekar. The patients of CA breast, they are having lymphedema. So there is, because of the lymphatic obstruction, and the lymphatics, they are identified, and they are anastomosed to the nearby vein, thereby reducing the lymphatic edema. So that is how the lymphatics, they are identified, and these lymphatics, they are anastomosed to a nearby vein. So organ detection and ICG is also an important point to be discussed. Parathyroid, they have self-illumination in ICG, infrared imaging, but many times they are not identified during thyroid surgery. So we will see how they are to be identified. We are giving a continuous infusion. All endocrine tissues, they are very having high metabolic rate, so they clear the dye very fast. Therefore, all the endocrine tissues, they, if want to see the pathology, we have to give the infusion mode of installation. So that is how the parathyroids, they are detected by this. False negative detection is there because the blood supply to parathyroid, if it is compromised, so dye is not reaching. So this is a beautiful picture. The first line of picture, first three from above downward, this is the parathyroid here, but in black and white image, there is no dye seen there. So, and in the ICG view also, there is no dye seen. So this particular parathyroid is completely devascularized. So we can pick this up, this particular parathyroid gland, and put it into the sternocleidomastoid. And in the middle pictures, there is moderate vascularization. And if it is well vascularized, the black and white image is also very well vascularized, and the green image is also very well vascularized. So that is saved properly, that particular parathyroid gland is. So this is a beautiful video where a young lady with bilateral pheochromocytoma, left-sided it was adenoma, and she didn't want the post-operative adrenal insufficiency. The adrenal crippleness she was knowing, otherwise she would have been with the lifelong steroid supplementation. So we are at the level when we are at the surface, at the just detecting the pheochromocytoma. So we have given the ICG dye by continuous infusion, and then we have detected that adenoma. This particular patient already had one adrenalectomy, the right-sided adrenalectomy previously, and now she is having a second on the opposite side. So we wanted to save the gland, rest of the gland. Only we wanted to remove the adenoma. So that is how it could be done with the help of ICG. So that is parenchyma saving adrenal surgery. So that particular adenoma was removed. And even in lung pathologies, those lung nodules which are not visible on the white light, they are visible beautifully by the ICG technique here. So in bariatric surgery, the gastric calibration tube and ICG compatibility, this particular ICG is inserted with a LED system, and then dye was instilled, and it was eliminated during surgery. So sizing of the sleeve can be done properly. You can see how the sizing can be done properly with the help of the illuminated tube. Gastric calibration tube is visible, and then we can staple it properly, and proper sleeve can be sizing can be done. Even in redo bariatric surgery, there are lot many patients with redo bariatric surgery. Chances of leakage are very high as compared to the primary surgery in redo bariatric surgery. Here we are doing a redo bariatric surgery, and we wanted to see the vascularity of the gastric pouch. And you can see that the uru limb is there, then gastric pouch is there. And now we wanted to see whether, yeah, this is the devascularized gastric pouch. So we will have to remove that, refashion it, and then do the anastomosis. So that is how it will help. Then we can see the mucosal integrity in the Heller's myotomy. You can see in first video, the complete mucosal tube is seen beautifully, but we wanted to see whether any fibers they are remaining there or if there is any leak. So in second video, you can see, so how that can be done. The dye can be instilled directly into the esophagus with the help of Files tube during this particular procedure, and you can see complete mucosal tube very well. And if there is leak, with that, in one patient we had a leak which was not visible by white light, and that leak was there because it was identified with the help of ICG, and we could manage that thing. In SMS syndrome, the artery is very prominently seen, but the vein is very delicate and it is less commonly seen. So we are to dissect during our laparoscopic surgery management of SMS syndrome. So we can give ICG dye to localize the exact position and extent of the position of the vein during by giving the ICG, and therefore we can prevent injury to the vein. So that is how, because it is very snugly fitting and very adjacent to the DJ lecture. So that is how we can very well identify it. In gastric cancer, we can instill the dye at least 24 hours before endoscopically at 4 quadrants, and we can visualize it intraoperatively. Do a proper lymph node dissection. All illuminated lymph nodes, they can be removed. And after removal, we can examine the bed for any remnant malignant tissue, and therefore we can achieve a better results in even carcinoma stomach. So indocyanin green in gallbladder surgery, we have not discussed anything about gallbladder till now, but it is a GPS in surgery for the gallbladder surgery also. So we will see how that is effective. The fluorescent cholangiography and the conventional radiological cholangiography, there is a vast difference, as this is detected by this particular slide. There are many advantages. It is very no radiation. It is less time consuming and less costly as compared to the conventional intraoperative cholangiography. So now the SAGES has come up with, previously SAGES was saying that we have to follow the 6 steps of cholecystectomy during safe cholecystectomy. Now they have come up with the 10 step of cholecystectomy with the advent of the ICG technology. So the step 1 is injecting ICG 60 to 90 minutes before, then laparoscopic camera keeping complete focus on hepatocystic area, removal of the pericholecystic adhesions, removing of the duodenal adhesions, and the infundibulum retracted down. So that is step 2. And in step 3, localization of the main biliary structures at the hepatocystic triangle. So primary objective of step 3 is localization of the main biliary structures. In step 4, 5, 6, 7, and these steps, we have to identify cystic duct, gallbladder, and cystic duct junction. Cystic duct and common hepatic duct junction is also to be identified. Previously, we were not supposed to identify the confluence of cystic duct with common hepatic duct. But now, with post-cholecystectomy syndrome patients, SAGES has come up with this particular idea that the cystic duct common hepatic junction is to be identified, the complete CBD is to be identified, and then if at all in empyema cases, this particular study, the gallbladder and the cystic duct is not identified, then we can instill the dye intra gallbladder during the surgery itself, and we can do the step 4 to step 7 to attain the intracol proper anatomical visualization. And in step 9, again, the timeout, and it consists of re-evaluation of the CVS before this thing. So this is a video of critical view of safety intraoperatively with the help of ICG and with the help of green white light. So I will just fast forward it so you can see how the confluence of the cystic duct with the common hepatic duct is identified, and the complete all 6 marks, 2 marks each for the cystic ducts, the artery, and the clearance of lower 1/3 of the gallbladder fossa. So that is how it is well identified with the help of ICG. So this is very important to prevent catastrophe during gallbladder surgery. So anterior and posterior views both are to be identified properly. So in step 9, you can see there are sometimes some surprises, anatomical surprises. Here there are 2 parallel tubes going down, but now you can see that the cystic duct is hinged up. There is a V-shaped. So that means the posterior sectoral branch is attached there. So the cystic duct is short, and the rest of the thing is the posterior or the right hepatic duct coming down separately. So that is how. Otherwise, without this view, we would have clipped the thinking that the cystic duct is very long. Here we can see very well, and the catastrophe was avoided here. And after completing the gallbladder removal, near infrared light should be turned and identify any potential biliary leaks from the liver bed. So that is how the 10 steps are there. This is the caterpillar hump. So vascular anatomy can also be visualized very well. How many arteries going toward the gallbladder, they are to be seen. Otherwise, there will be inadvertent bleeding during your dissection. So ICG dye has been given now, and the dye will appear into the artery within 15 to 16 seconds. Now the dye has appeared there, and it will remain there in the vessel for at least 4 minutes. So during that 4 minutes, you can observe completely the anatomy, vascular anatomy. So this is how we have published our case, the Japanese Journal of Gastroenterology, classification of caterpillar hump. Depending on the various situation of the caterpillar hump, as compared to the cystic duct. So how the accessory ducts can be visualized very well. This is a beautiful video. Simple cholecystectomy, gallbladder seems to be very simple, and CBD is already visualized. Patient is not much high BMI, and see the surprise now. I will fast forward a little bit. Yeah. Now the accessory ducts, they are visualized there at the near the liver, and yes, there is the accessory duct. So these ducts can be, many times you think that I have done very good job, but still there is a bile leak. So these are the cases where bile leak can be there. I will go back and will again show. Yeah, this is how the accessory ducts. One is coming directly from the hepatic duct, and one is coming from the right hepatic duct and going along the gallbladder close to the liver surface. So that is how the leaks, even when you think that you have done cholecystectomy properly. In cirrhosis, parenchymal function can be judged with the help of ICG, that the hepatologist or the hepatic surgeon, they are doing it. So only the nodules which are illuminated here with the green color, they are functioning. Rest of the nodules, they are non-functioning. So in empyema, usually the need for subtotal cholecystectomy has gone down. Subtotal cholecystectomy is a beautiful procedure, very a procedure which will save the patient as well as the surgeon. So here in this particular patient, how the intracystic gallbladder, intracystic installation of ICG dye is to be done, we will see. We will drain out completely the contents of the gallbladder, and we'll do little bit of dissection so that our purse string suture will fit there. And with a small 3 mm port in the mid-clavicular line, we will put a catheter, and through the catheter we will instill completely the dye inside the gallbladder, because the gallbladder is not getting visualized because of the ICG, and there is a block at the level of the cystic duct. Sorry. So there is no visualization of the gallbladder, no visualization of the biliary tree, extrahepatic biliary tree. We have increased the SPY gain. In spite of that, there is no visualization. So we will put the dye directly into the gallbladder, and then again we will see what is going to happen. So we can sometimes identify the anatomy very well, and we can get the idea where exactly is the common bile duct, where exactly is the confluence, where exactly is the common hepatic duct, and thereby the subtotal cholecystectomy need can be avoided. So we can instill directly the dye inside the and then we can see anatomy at the callos. So this particular patient again had empyema gallbladder, and we will see how the infection is there in the liver, multiple cholangitic abscesses. To white light, it appears normal, absolutely normal liver, but there is an empyema. So we will turn on, yeah. Now we can see the illuminated and non-illuminated areas. Abscess will have non-illumination, and the liver cells will have. So this is a classical picture of multiple cholangitic abscesses. So that is how we can warm the patient, and we can step up our antibiotic profile by doing this. Many a times the vascular tree will tell you the multiple cystic arteries. So here we can see this is the cystic duct and this is the caterpillar hump going, supracystic caterpillar hump, and it is a long cystic artery, and there are multiple 1, 2, and 3, 4 cystic arteries with the along the cystic duct. That is how the vascular anatomy is also very well visualized with the ICG dye. In undescended testes, when you are doing laparoscopic surgery, you have to cut the vascular supply of the patient vascular pedicle so as to have the better mobilization of the testes. So the blood will be coming from the testicular, the artery to vas, and from the gubernacular side. So I will try to fast forward it because everybody knows this particular procedure. And then we will be giving the ICG dye after complete mobilization of the artery and cutting the vascular pedicle. We will see how the artery is visualized. We are giving 3 ml of dye intraoperatively. So the artery has come up, the testis has come up, and we will see the vascularity of the testis. So that is being delivered into the inguinal region and then into the scrotum after completely mobilizing the testes laparoscopically. So it has come up, and we'll see. So bilaterally, so there is green color to the testes. That means the testis is well vascularized, so it will not necrose. So, but there is a lot to be discussed still with the hernia surgery, then fistula in ano, then plastic surgery, nephron saving surgery, in cardiac surgery, redo bariatric surgery, lot to be discussed. Post HBOT treatment monitoring can be done with the help of ICG. In mucormycosis surgeries, there are definitely some controversies, the limitations. So this is a horror man named Pale Man who has his eyes in the hand, and we should have we should not be doing any horror stories, but we should be utilizing our knowledge. We should have our eyes in our hand, and our eyes are direct, then analog, then various camera systems, and the image guided surgery, such as with the help of interventional radiology, the laparoscopy, endoscopy combination, enhanced reality, augmented reality, and then virtual reality, which is coming up now. This ICG technology is going into the 3D technology also combined with that, and the depth of the detection of the tissues in this particular case, CA breast with internal mammary lymph node can be visualized very well. So thanks a lot about that. ICG is becoming an important GPS in surgery, and it is going to change the standard of care of many procedures. Its use should be made more generous in surgery. So I will stop sharing my screen. Thank you very much.
Amazing, sir. Amazing. Thank you very much for this very, informative and rather an eye-opening lecture on a use of technology which is very easily available. Although the hardware is expensive, but the repeated expenses are very minimal. And this was a actual eye-opener and a curtain raiser and a new paradigm of things and the scenarios where it can be used was at least I heard it for the first time, many of these applications. Over to Gode sir. Sir, can you just give?
It was, thank you, Prashant.
Thank you, sir.
It was really wonderful presentation, and you have shown the use of ICG in great details, and probably you have not left any system where ICG cannot be used. So, and for others, knowledge that we call Prashant Rate as a ICG man in AMASI. So thank you, and thank you very much. And I hope what was the most important in this is how you could make the surgery safe. That is very important. And to make the surgery safe, we need to use meticulous dissection, but as well as if the technology is available. So this is one technology, and I hope the artificial intelligence is one more, which is going to come very in a very short period of time, but then that also be using some form of technology. So all these technological advances are basically meant to ensure that the surgery is going to be safe for the patient. Thank you very much, Prashant. It was really fascinating and really very interesting to hear all the uses of ICG. Thank you. Thank you, Nirmal. And thank you, Girish, for you being there as the participant for this first ever zonal meeting. So nicely done. Congratulations. Thank you.
Thank you, sir.
For the mesmerizing talk, sir.
Are there any questions from the audiences? Like, do we have? I don't have anything on the chat. So, are there any questions from the audiences they can ask? So, except for the intra-arterial injection, technically it appears to be very simple, where you can give a ICG intravenously. You can ask the anesthetist, and you just have to switch on the mode of the camera and switch on to the contrast mode whenever necessary. Right, sir?
Yeah, it is very simple.
Yes.
You have to use the technology. If you are purchasing that particular technology, you can use it at many levels, at least 2 to 3 times in a day.
Yes. Correct.
And you, regarding that arterial injection also, that is very simple technique. It is not so difficult technique, because we are going to do, primarily we do
Dissection. Yes.
the resection at that particular level. So we have to go down, properly apply clamps, the bulldog clamp there, and do the cannulation, and just put the dye there. So the rest of the time is saved.
Okay. Correct.
We need not worry about the ureter. We need not worry about the location of the nerves, because they are not at all in your field.
Yeah. So that detection of the embryonal planes was something very new concept that I learned today.
Yeah.
Fantastic, sir. Thank you so much. Thank you so much.
We have done almost 7 cases now.
Okay.
And every time we could do it very fast.
Right. Just you have to, remove the green area, and you can save the rest of the structures. Right. Right. Zatkar sir, any comments, sir?
I wanted to know whether this multicolored view, what he told us, is available by laparoscopic camera, or we have to have a.
Sir, that is available with only one system, Arthrex type of camera system. That has come into India, and that is along with the normal ICG view. They are giving the different color images also for the patients, those for the doctors who are colorblind to that particular. And after seeing this, they have even done one study that after going through that multiple colored vision, many of the doctors, they came to know that they are colorblind. Colorblind to green or colorblind to red.
Achha.
That is the commonest color blindness, to green and red. They are confusing with the red and green, and that is the tissue. ICG is always visualized as green, and blood is always there as red. But they are not knowing, the surgeons are not knowing that they are colorblind till they see this particular, they have detected, I am not exactly remembering that figure, but the surgeons, they have found after seeing that image that they are color.
8%.
8% of males and 0.4% of females in general population, they are colorblind.
So the surgeons.
Yeah.
Right. So once again, sir, thank you so much for this very illustrious and very informative talk. And with the permission of Gode sir and Jatka sir, can we now conclude this meeting?
Yes.
Yes, sir. Thank you very much, all of you, and good night. Good night from all of
Thank
us.
you. Good night. Thank you.